Major depressive disorder, or MDD, hits females disproportionately hard. The disease itself takes a severe physical toll. Over 70% of people with untreated depression report significant impairment in their sexual function. This visualization illustrates a harsh reality. On the left, we see that 70% baseline of impairment from untreated MDD. On the right, we see the effect of standard treatment. Up to 80% of patients taking SSRIs experience an induced sexual dysfunction, or AIDS. Early drug trials relied on passive reporting, which masked the true scale of the problem. Look at how this chart shifts with direct inquiry. It contrasts a 14% placebo baseline against an 80% incidence rate tied to SSRIs. Antidepressant-induced sexual dysfunction is a predictable, structural consequence of how these drugs are designed to work. The standard of care for depression creates a profound clinical catch-22. Patients and providers inadvertently trade a symptom of the disease for a direct side effect of the cure. This dynamic begins incredibly early. By adolescence, girls are nearly 3 times as likely as boys to experience a major depressive episode. Over the last decade alone, that rate has jumped by 37%. Consequently, young, physically developing females make up one of the fastest-growing demographics receiving prescriptions for highly potent SSRIs. Exposing this specific demographic to these medications carries a severe tail risk. That risk is post-SSRI sexual dysfunction, or PSSD. PSSD features severe symptoms like genital anesthesia and a persistent loss of libido that do not resolve when the drug is stopped. These physiological impairments can continue for months, years, or indefinitely. The true prevalence in teens is hidden by flawed data. Standard pediatric trial protocols have reported 0 cases of sexual dysfunction in adolescents, entirely because they expect teenagers to spontaneously bring up these highly intimate issues with adult researchers. Prescribing these specific agents to adolescents without rigorous, transparent conversations about PSSD risks, inflicting permanent psychosexual developmental harm under the guise of standard care. To understand why this happens, we have to look closely at the chemical exchanges driving the female sexual response cycle. This 3-part matrix models a healthy neural synapse. The green section highlights dopamine, the primary excitatory neurotransmitter for sexual motivation and arousal. Adding to the model in yellow is norepinephrine. This dual-role pathway facilitates physiological aspects of arousal, including climax. Excessive norepinephrine triggers counterproductive anxiety, so sexual function requires a very narrow, optimal range. Finally, the red section represents serotonin. Serotonin is the primary inhibitor of the sexual response cycle, the physiological brake system. Healthy female sexual function relies entirely on a precise neurochemical equilibrium. The dopaminergic excitation must consistently outpace the serotonergic inhibition. Selective serotonin reuptake inhibitors, like the 20 mg fluoxetine shown here, and serotonin norepinephrine reuptake inhibitors, or SNRIs, operate by blocking the synaptic reabsorption of neurotransmitters. Returning to our synaptic matrix, this reuptake inhibition creates a dense artificial concentration of serotonin lingering in the synaptic cleft. This potent serotonergic enhancement creates a state of serotonin dominance, physically and systematically suppressing the excitatory dopamine and norepinephrine pathways. The clinical manifestations are severe. Up to 72% of females report decreased libido, and up to 42% experience anorgasmia, the inability to reach orgasm. Paroxetine, sold as Paxil, and venlafaxine, sold as Effexor XR, are potent serotonergic agents carrying the highest risk profiles for these specific side effects. The specific neurochemistry required to resolve the depressive episode predictably antagonizes the neurochemistry required for sexual excitation. Adult female patients frequently report profound quality-of-life impacts, detailing symptoms like complete genital numbness or a phenomenon termed pleasureless orgasm. There is a pervasive misconception within the medical profession that these side effects are rare, easily reversible, or simply an acceptable trade-off for resolving depression. Antidepressant-induced sexual dysfunction creates a pernicious negative feedback loop. The resulting loss of relational intimacy undermines the exact psychological recovery the medication was prescribed to achieve. This specific, highly distressing side effect profile becomes a primary driver of unmonitored medication non-adherence as patients silently stop taking their pills. Tolerating high rates of medication-induced sexual dysfunction represents a critical blind spot in standard psychiatric care that actively jeopardizes overall patient recovery. Evidence-based management of this condition begins with establishing a thorough pre-treatment baseline of the patient's sexual function. This baseline is physiologically imperative. It allows clinicians to accurately separate the inherent symptoms of the depression from the medication-induced dysfunction that may emerge later. Look at this clinical decision tree outlining the AIDS management protocol. The critical first step requires proactive monitoring using objective scales. Moving down the tree, passive strategies are explicitly contraindicated. Watchful waiting is crossed out because spontaneous resolution is exceptionally low. Similarly, drug holidays carry a severe risk of depressive relapse. Overcoming clinical inertia requires providers actively hunting for symptoms through structured protocols. If dysfunction emerges, the primary strategy is switching to a non-serotoninergic agent, highlighted in the next node. Clinical studies show up to an 84% improvement rate when patients are switched from high-risk SSRIs. For patients managed on an SSRI who still suffer dysfunction, the final node outlines a secondary strategy, pharmacological augmentation. Bupropion is a norepinephrine dopamine reuptake inhibitor, or NDRI. It effectively manages depression by enhancing dopamine and norepinephrine without aggressively elevating serotonin levels. Newer multimodal agents like vortioxetine also successfully bypass this serotoninergic bottleneck. The most robust evidence-based augmentation strategy involves adding 150 milligrams of sustained-release bupropion twice daily to directly counteract the existing serotonergic suppression. While medications like sildenafil, shown here in its commercial Viagra packaging, are often prescribed off-label for women, they have highly mixed efficacy. They generally fail to resolve deficits in subjective desire because they do not address the neurochemical bottleneck. Outside pharmacology, behavioral interventions like 30 minutes of combined cardio and strength training immediately prior to activity can effectively prime the autonomic nervous system. By utilizing mechanism-based prescribing and precisely leveraging dopamine and norepinephrine pathways, clinicians can effectively cure depression while fully preserving the patient's vital psychosexual well-being.
Thanks for watching. If you learned something from this video, please subscribe to the Concierge Care channel. You can find us at health.conciergecare.net. Follow our links to other videos on deeper dives into the selected topic and related articles on the discussed subject. Don't forget to enable notifications so you don't miss our next uploads and live events.